Hello, I want to welcome everybody to this session of our Sagis Diagnostics Happy Hour. Today, we're going to be taking a look at a sampling of epidermal tumors and a few of their histologic look-alikes. As always, if you have any questions, you can send them to education@sagisdx.com or you can email me directly, tdavis@sagisdx.com. So without any further hesitation, let's go ahead and get started. As I'm sure those of you who have looked at the deck ahead of time were able to ascertain, the first three entities that we'll be discussing have a very similar architectural silhouette, and they're both, or all three rather, characterized by clonal proliferations or islands of cells in the epidermis. So let's go ahead and begin with these three. The first case number one, the correct diagnosis was a clonal seborrheic keratosis. And one can see in these sections that we have slight acanthosis of the epidermis. This lesion has a very benign silhouette. It's broad, but it's got a very flat bottom. And if we move to slightly higher power, we begin to see that the quantified layer is slightly thickened by basket weave hyperkeratosis, as our most seborrheic keratosis. The epidermis is gently papillated. This particular lesion does not have a lot of horn cyst, and a lot of times in a clonal seborrheic keratosis, they won't be as prominent of a feature. If we look at the epidermis, you can see that we've got these clones or nest of keratinocytes situated in the epidermis. And as is the case with clonal seborrheic keratoses, the keratinocytes comprising these nest or islands are fairly monotonous and uniform. There's no significant cytologic atypia. They have round to oval nuclei, which are not variable in size and shape. And the chromatin pattern is fairly even as well. There are no mitotic figures, no overlying parakeratosis, and certainly there's no host response here. There is a slight increase in the amount of melanin pigment within basilar keratinocytes. So this, I thought, was a real classic example of a clonal seborrheic keratosis. Moving on to slide 2. Let me tilt the slide. The correct diagnosis in this case was a clonal variant, if you will, of squamous or Bowen's disease. And the silhouette, as you can see, is very, very similar. I mean, if you were to black this out, it would have a very similar silhouette to the clonal seborrheic keratosis that we looked at. As we move to higher power, we begin to appreciate there's a little bit more of a host response, a lichenoid infiltrate. And when we look at the quantified layer, you begin to see that in addition to basket weave hyperkeratosis, there are also zones characterized by fairly pronounced parakeratosis. And the parakeratotic cells themselves are kind of atypical. I mean, these nuclei are pleomorphic and some of them are hyperchromatic. If we look in the underlying acantholytic epidermis, again, we can see these nested aggregates of keratinocytes, but these cells are hardly uniform. The nuclei are extremely pleomorphic, markedly variable in size and shape. Some of these cells have prominent nucleoli, and they're readily identifiable mitotic figures, some atypical here. We've got some really bizarre looking multinucleated cells. We do have a little bit of an eyeliner sign, which we'll see in squamous situ, where we get compression of the basal layer here. And the key feature here was recognition of the fact that, one, we're on sun-damaged skin, and two, there are zones in which we have more typical Bowen's disease with full thickness cytologic atypia involving the epidermis and premature keratinization. And again, note the abnormal parakeratotic cells within the stratum corneum. So what distinguishes, of course, this from seborrheic keratosis is the clones or nest of highly atypical epithelial cells within the epidermis. Moving on to slide 3. Slide 3, the epidermis was a little bit more acanthotic, and yet we do have a very benign silhouette here. This lesion appears to be symmetric and sharply circumscribed. You can see the edges of the lesion. Again, kind of a flat bottom. And we've got a very acanthotic epidermis. And if we take a look on higher power, we can see that we've got these large clones of keratinocytes kind of sitting and expanding the epidermis. And there's a real sharp cutoff between the normal appearing keratinocytes in this zone and the cells comprising this proliferation over here. We've got a very monotonous population of cells comprising this lesion. These cells are quite uniform, like we saw with the clonal seborrheic keratosis, not much nuclear variability, even chromatin pattern, no mitotic figures or apoptotic cells like we saw in Bowen's. Of interest, note the stroma of this particular proliferation. It's kind of edematous with prominent vasculature. And that is a very common stroma that we see in ductal neoplasms, in glandular neoplasms, particularly eccrine tumors. And if you took a look in areas, you could see that there was evidence of small duct formation within this tumor. And so the correct diagnosis in this particular case is a poroid tumor. And in particular, we have this poroid tumor showing differentiation towards the acrosyringium or intraepidermal portion of the eccrine duct that is confined to the epidermis. And so this is a Hidroacanthoma simplex. And so you can see that there is a lot of histologic similarity, especially with the architecture between a clonal seb-K, uniform cells, no atypia, but no ducts, Bowen's disease, in which the nested aggregates have clearly pronounced cytologic atypia, usually overlying para, and a Hidroacanthoma simplex, which, like the clonal seb, has nested aggregates of uniform cells, but typically shows ductal differentiation. And again, I find this edematous and somewhat vascular stroma to be a clue as well to the diagnosis of a Hidroacanthoma simplex. Okay, let's go ahead and move on to slides 4 and 5. There's some similarity here that we'll discuss between these two lesions. So slide number 4, the diagnosis was a clear cell acanthoma. And one could see at scanning magnification that we've got a fairly discrete acanthoma here. The epidermis centrally is acanthotic, a little bit dome-shaped here. So in many respects, it has the configuration of the first 3 lesions that we looked at, kind of a discrete keratosis. If we move to higher power, we can see that the cells comprising the keratosis are clearly lighter staining than the adjacent epidermis. And indeed, there is a distinct transition zone between the darker staining keratinocytes of the adjacent epidermis and the lighter staining cells comprising this proliferation. No significant cytologic atypia here. And these findings are very characteristic of a clear cell or pale cell acanthoma, which likely represents just a benign keratosis, possibly even a seborrheic keratosis, in which there is a localized phosphorylase deficiency and accumulation of glycogen. Now, of note, take a look at the suprapapillary plates. They're thinned. There are dilated vessels here. And if we look in the cornified layer, there are even a few neutrophils. So there is histologic overlap between the changes in a pale cell acanthoma and psoriasis, okay? And you're on any certifying exam or any exam you take, they're always going to list psoriasis in the differential of a pale cell acanthoma because of the architectural similarity between the two. And slide number 5 was an example of plaque-like psoriasis. So let's take a look here. and we can talk a little bit about the differences. As we move to higher power, you can see that the epidermis is clearly characterized by a very acanthotic epidermis with bulbous, uniform reedy. If we look at the cornithite layer, we can see that there's confluent parakeratosis, and there are a few areas in which one can see neutrophils sprinkled throughout the cornithite layer. There's an absent granular layer. The suprapapillary plates are quite thin in areas, and there are several dilated and tortuous vessels in the papillary dermis, closely approximating the undersurface of the epidermis. And I even found a few suprabasilar mitotic figures as well too. So a lot of histologic overlap between pale cell acanthoma or clear cell acanthoma and psoriasis. However, if we take a look at the epidermal staining pattern, it's uniform across the specimen. We don't have that distinct transition between darker staining cells in the epidermis and the lighter staining cells of the pale cell acanthoma. So that, going back to the pale cell acanthoma, is what distinguishes the two entities. So if you don't see this distinct transition, then you're probably dealing with psoriasis and not a pale cell acanthoma. So that's your key histologic feature there. Let's go ahead and move on to slide number 6. Slide number 6 was a real nice example. Let me tilt it back, of a warty dyskeratoma. We've got a bisected shade biopsy here from the face, large sebaceous gland here. This lesion has been transected, but we can see we've got a cup-shaped invagination. If we take a look at the keratinocytes comprising this invagination, they show evidence of orderly maturation. We do have these villous projections extending out from the cystic invagination, but there's no significant cytologic atypia here. The cells are quite uniform, and this isn't really from particularly sun-damaged skin. When we look along the luminal aspect of this invagination, we see the epidermal reaction pattern of FAD, focal acantholytic dyskeratosis, with clefting, a lot of acantholytic cells, and pronounced dyskeratosis involving most of the cells in the central portion of this lesion. And again, it's best to think of warty dyskeratoma as either a dilated cyst, a dilated follicle, or a ductal structure showing the epidermal reaction pattern of FAD. Which leads us to slide 7, because one can see acantholysis in neoplastic processes as well. And so on the differential of a warty dyskeratoma, you're probably always going to see included an acantholytic squamous cell carcinoma, which is what slide 7 represented. We've got a dome-shaped papule. This is clearly from sun-damaged skin. If we take a look at the epidermis in areas, we can see there's clear-cut AK. So we've got crowding of basilar keratinocytes with nuclear pleomorphism and overlying stacks of parakeratosis. And it's in this setting that we've got this endophytic epithelial neoplasm extending into the dermis. And if we take a look at the cells here, we can see that their nuclei are much more pleomorphic and hyperchromatic than we saw with the warty D. Here's a mitotic figure. There are apoptotic cells, but notice that there's also pronounced acantholysis and dyskeratosis. So obviously, acantholytic squamous cells will have both acantholysis and frequently dyskeratosis. This doesn't have the cystic invagination, nice cystic invagination that we saw with the warty D. And again, the presence of cytologic atypia, especially if there's associated actinic keratosis, is what allows one to distinguish a warty dyskeratoma from acantholytic squamous cells. So you're going to have to go down and look at the cytologic features sometimes to distinguish the two. Slide 8 and 9 bring up a very similar discussion. So let me tilt the slide here. and move it over. In slide number 8, the correct diagnosis was an acantholytic AK. And you can almost make the argument here for superficial squame because there appear to be a few detached aggregates present near the base of the biopsy specimen. But again, severely sun-damaged skin, okay? And we've got buds of atypical keratinocytes with clear-cut crowding of the nuclei and some nuclear pleomorphism, an overlying parakeratosis, buds and cords of these atypical keratinocytes attached to the overlying epidermis by necks. Notice, though, that we do have acantholysis and dyskeratosis. Again, some more buds of atypical keratinocytes with some acantholysis and dyskeratosis. So much as one can see acantholysis in a squame, you can also see acantholysis in an actinic keratosis. And the contrast here is with case number 9. And admittedly, in the absence of history, it would be difficult to come up with the specific diagnosis in this case, but this was from a patient with Grover's disease. The take-home point here is that we have a shade biopsy. There is suprabasilar acantholysis with dyskeratotic cells, but if you take a look at the epidermis, notice we've got a basket weave cornified layer, and there's evidence of orderly maturation. We don't have nuclear crowding or appreciable cytologic atypia of basilar keratinocytes. There's no evidence of AK here. And we do have the epidermal reaction pattern of FAD, focal acantholytic dyskeratosis. I happen to know that this was from a patient with a pruritic eruption, and the clinical impression was that of folliculitis versus Grover's disease. If I didn't have that history, I would sign this out as focal acantholytic dyskeratosis and state that it's an epidermal reaction pattern that can be seen in a variety of conditions, including Grover's, Darier's, and isolated keratoses. So you need the clinical to arrive at the diagnosis. But I wanted to contrast this with an AK, with the acantholytic AK, and again, with the squamous cell carcinoma and with an actinic keratosis. The way you distinguish those from primary acantholytic disorders rather than neoplasms is the presence of significant cytologic atypia. So quick run through here. I hope you found the discussion helpful. And again, if you have any questions, please feel free to email me. Thank you very much.